Advance Directive and DNR use amongst patients undergoing radiation therapy. Advance directives allow patients to express their wishes regarding life-sustaining treatment and designate a surrogate decision-maker. They were created to protect patient autonomy, especially in stages of their life when they may have become incompetent. If a patient loses decision-making capacity, they are more likely to receive the care they desired if they have their decisions clearly documented, or if they have designated a surrogate decision-maker. Oftentimes, patients do not complete advance directives, which may lead to increased utilization of medical interventions without necessarily knowing if the patient desires them. The discussion of making an advance directive is often initiated late into a patient's illness, adding additional stress on the patient. Early and effective communication is essential to a patient coming to terms with their diagnosis. Early determination of goals and wishes allows for better quality of life through the duration of the illness. Advance directives are also beneficial to the patient's family. Without clear wishes, decisions often fall to the patient's family if the patient lacks capacity. This burden can cause additional stress to the family in an already difficult time. An advance directive has been shown to increase patients' and family satisfaction and decrease their stress, anxiety, and depression. Advance directives are critical tools in bettering and clarifying end-of-life care and increasing patient autonomy. Thus, any intervention that would increase advance directive participation would be beneficial for patients, families, and providers. Our goal with this project is to establish baseline levels of advance directive participation so that the effects of future interventions may accurately be assessed. We established our base population by using the Beaumont CRDB. All cancer patients were selected using cancer-related DRGs, and then were filtered for those receiving radiation using the ICD Z51.0 Encounter for Antineoplastic Radiation Therapy designation. This population was then split into those with and without advanced directives by using the CPT codes 99497 and 99498 for advanced care planning. The demographic data, namely age, sex, and race, were extracted at this point. Finally, in order to determine the metastatic status, the ICD codes C77 to 80.0, which designate secondary metastases, were utilized. This all was replicated for DNR status, as it was felt that it would provide a proxy, albeit an imperfect one, for advanced directive type conversation. This made use of the ICD Z66 designation, which codes for DNR status. Using Microsoft Excel, the various required statistics were calculated. Ages were interpreted with a single sample t-test, and the race, sex, and metastatic status were calculated with binomial probabilities. These are the baseline characteristics of the population of cancer patients receiving radiation. From this population, we will compare the subsets of those with and without advanced directives and DNRs. The mean age is 65, with a standard deviation of 13. As we can see here, the population skews slightly female, even when compared to the surrounding Oakland County population. The racial demographics of this population seem to overrepresent white patients at the expense of essentially all others. Again, this is compared to the surrounding Oakland County population. As a note, the Hawaiian Island population had to be omitted due to insufficient data to calculate meaningful statistics. Now when we add in the advanced directive data, we can see a few things. The patients with advanced directives are 5 years older than the base population, a significant difference. The patients without advanced directives were identically aged. Sex seemed to have no significant difference on whether a patient would or would not have advanced directives filed. A quick note on the conventions here: each triplet of values contains the raw sample value, 69 in this case, followed by the difference in direction between that raw sample value and that predicted by the population, there being 1.61 more women with advanced directives than you would expect based on the baseline frequency of women in our population. And finally, the probability, 42% in this case, that this number, or any more extreme than it, would occur by random chance. Those are the numbers we'll be using to determine significance. Regarding race, there are some stronger trends in the population with advanced directives, but nothing even close to the level of significance. Even these hints disappear in the population without advanced directives. Now we can start to see some levels of significance appear. In those patients with advanced directives, there's a significantly higher proportion who have metastatic disease. This difference again disappears in the patients without advanced directives. Now let's take a look at the DNR data. Similar to the advanced directive population, those with DNRs tended to be significantly older than the base population, but unlike the advanced directive population, this group had a significant tendency to be younger as well, but only by a year. Regarding sex, again we see significance when the data is split by DNR status. There were significantly more men with DNRs and significantly more women without. Here, with race, we see some more texture, but again, nothing approaching significance in either those with or without DNRs. Finally, those with DNRs were more likely to have metastatic disease, similar to what we found with the advanced directive data. But the mirror of this is found in those without DNRs. They were less likely to have metastatic disease. Here's all the data in one spot, just for reference's purpose. Moving to the discussion, only 1.6% of patients had a documented advanced directive. Given the benefits of the advanced directive we talked about earlier, this is far too low. The 20% of patients with DNRs is certainly better than the advanced directives, but there's still plenty of room for improvement. Both advanced directives and DNRs are found more often in older patients and in those with metastatic disease. This is to be expected, as these patients are usually more aware of their prognosis than a younger patient or a patient without a severe disease burden would be. These patients are then more willing to discuss these more imminent issues. We found no evidence at all of race-based discrimination in the rates of advanced directives or DNR discussions in any of our analyses. A surprising finding was that women were significantly less likely to have a DNR status. This disagrees with several studies found in the literature where women were significantly more likely to have DNR statuses on file. though these were in neurosurgical and cardiac patient populations, so it's possible that our observed difference might be the result of our oncologic patient population. Regarding the limitations for our study, the DNR does not serve as a perfect proxy for advanced directives. It only provides a proof that the conversation resulted in an affirmative DNR. It does not differentiate between an active decision to remain full code with a thorough discussion and a total lack of conversation. Relying on ICD and CPT codes will only catch official documentation of these discussions, while patients are certainly capable of making their wishes clear and known in other ways. There's likely a tremendous amount of variation and inconsistency in documentation and coding, which likely compromises the reliability of the metastatic status, certainly. However, to what degree would be difficult to ascertain. Finally, further investigation into the relative lack of DNR statuses being obtained for women would certainly be illuminating. There may be some correlations between the types of cancers and the relative usage of advanced directives and DNRs, which might reveal some important associations. And finally, there remains much work to be done in increasing the overall use of advanced directives and DNRs. They're valuable tools that benefit doctors and patients alike. Thank you for your time.